Welcome to Make Visible, the podcast shining a light on complex chronic illness. I am your host, Emily Kate Stevens. Welcome back. This week, I bring you a wonderfully insightful and hopefully helpful conversation with Dr Melanie Hoppers of the Bateman Horne Centre. Physician, paediatrician, and a mother who has spent the last 10 years trying to help her daughter with ME/CFS. Here we discuss Post Exertional Malaise, PEM, and pacing, offering you a practical guide to understanding and recognising PEM, what to do when you have it, and ways in which you can use pacing to mitigate it. In terms of where you are now, you are an internist and a paediatrician. And in 2008, you co-founded the Physicians Quality Care Centre, which was there in Tennessee. And this was a multifaceted centre combining that real medical line of acute and primary care. But within that centre, you had the more, I don't know if holistic is too light a word, but you combined that OT, physio and wellness piece of things as if you were trying to actually help people get well.
We even had a gym for a while. We had to shut it down, but we had a gym. We were trying really hard, but the South is not particularly fond of healthy eating and exercise.
So in terms of your approach to healthcare and your approach as a doctor, tell me about that idea that you had to bring all of those elements, because I think that's so relevant for what you have ended up doing now. And it's a huge missing piece in a lot of healthcare.
So my thought was healthy eating, exercise are all very important. Obviously not for ME/CFS, but for people who don't have ME/CFS. Those are two things that I wanted to incorporate because lifestyle, again, in the South, our lifestyle is what kills us. And so we're just trying to help people make lifestyle changes as a part of their care. If you have a high cholesterol, let's help you lose weight. If you have a high cholesterol and diabetes, let's help you exercise appropriately. Obviously very different with ME/CFS because exercise is not something I prescribe. But it also goes back to the healthy eating, the environmental exposures. How can we limit those things, the chemicals that we're exposed to, and things like that? But yeah, that was my thinking when we opened the clinic. And my daughter was healthy then. And to be honest, I was like other people. I had not heard of ME/CFS. I've heard of chronic fatigue syndrome as part of my medical training associated with rolled eyes every time it was said.
Yeah.
This gal has chronic fatigue syndrome,
Yeah.
Wondering what's wrong with her mental health, whatever.
Yeah.
And I didn't feel that way. I always, when people came in looking back and I go, oh, now I know what was wrong with them. I always tried and I always was sympathetic, but I wasn't effective. I wasn't effective at treating them. Once my daughter became ill.
And that was 2015.
Yeah. 10 years ago. She was 10. Yes. And I had no idea. And then there wasn't as much stuff, but I still tried the whole, okay, we've got to get up. We've got to go to school. We've got to do the things. I didn't know about pacing. I didn't know about post exertional malaise. Over the year, I'm like, we go on vacation and she doesn't want to do anything. We go on vacation and she comes back. And I remember I finally found Dr. Bateman and her website, and I was reading. I was like, well, okay, this is exactly what she has. But PEM and pacing wasn't a part of anything. And I took her to doctors, and they were useless. She had POTS, and they didn't refer me to their POTS center.
It actually makes me well up slightly, because knowing what it's like for me to live with a chronic illness as an adult is hard enough. But the idea for her to be going through it, or for parents to be completely helpless watching their children and trying to advocate for them, I just think it must be.
It's incredibly painful. And what's incredibly painful is I don't know that we're that much better, maybe a little, but I saw a child this week, horribly ill, been to providers multiple times and, I don't know, prescribed exercise therapy, and a kid who could barely speak. We've got to get the word out about kids too. I mean, we got to get the word out about everybody, but it's incredibly, it's terrible.
Yeah.
It really is.
And that is one of the things that you finding the Bateman Horne Centre and joining, essentially being mentored, I'd say, by Lucinda Bateman and becoming part of what they offer. A huge part of what they do is that education piece. They are trying to share knowledge as well as the clinical work that you do. It's about educating patients and healthcare providers.
Right.
Now, it was actually in something that was written from NSU, who I am a huge fan of the team there at NSU, and an interview that you did. And they described that Bateman Horne Centre as somewhere that breaks down a vast amount of information into manageable pieces, making it easy for patients to understand and apply. And I just thought that was a really beautiful and succinct way to talk about the work that you do at the Bateman Horne Centre. And this interview, I would really, really like it to be strong practical advice for patients on post-exertional malaise and pacing. But I would first of all like to talk about this amazing piece of work that you and the Bateman Horne Centre have just created. And that is your clinical care guide, which is for patients and healthcare providers. Can you tell me what this document is?
So we try to break down how do we treat people with ME/CFS, long COVID, people with long COVID who have ME/CFS. How do we break down and take care of this illness? I remember when I had gone to the Bateman Horne Center and I'd spent about a month there learning, and I was all excited and ready to come home and start seeing patients. And I was thinking, I'm going to start slow. I'm going to start real easy. I'm going to find some people who are not so sick. I'm going to start there and I'm going to work my way up. And the first patient I saw was a teenager who was having multiple episodes of seizures every day. She had been labeled as having psychogenic seizures. And indeed, they were not psychogenic seizures. Treating her MCAS fixed her seizures. Right? And that was a shot in the dark on my part. I remember coming out of the room and going, oh no, what have I done? How did I get into this? Because I am in over my head. And I sat there and I thought a minute, and I thought about my daughter, and I thought about how no one was able to help us. No one else now, who's going to help her? So I have to try. So I did. And I got super lucky. And MCAS, because I knew she had symptoms of MCAS, I didn't think the seizures were MCAS. I didn't know what exactly they were. But when we treated her MCAS, her seizures improved remarkably, like from 10 seizures a day to 1 a month.
Wow.
Yes. I mean, completely changed her life with a couple of meds. I remember coming out and just feeling so overwhelmed. And I had the Bateman Horne Center that I could call. I have another group that I'm involved with that I can post a question and people will help. But there are providers out there who have no idea. So I didn't want them to come out of that room and give up like I was tempted to do that day. I wanted to give them something to help them. And well, the Bateman Horne wanted to do that, and they allowed me to be a part of it. And so this is to try to help guide them through treating a patient with myalgic encephalomyelitis chronic fatigue syndrome, whether it's because of COVID or whether it's because of mono or whatever horrible thing triggered their illness. It was really hard because everything you do, there's the art of medicine, right? You can look up in a book how to treat someone, and if you have never done it before, you know what the book says, but sometimes what you really do is a little bit different. So we tried to kind of put those things in there as well. For instance, when we start treating, especially teenagers, I take like a normal dose and divide it by 4 or 5, and I start there. And I slowly titrate up. I'm sure people look at my doses if they go somewhere and go, what are you doing? I have a reason, because you give them that full dose and they'll have all the side effects. It's too much. So you have to start slow. So we make sure we add those things in, principles, go low and slow, all those different little principles. And then we divided, orthostatic intolerance. What's the definition? You have either orthostatic intolerance or cognitive impairment. So there's a chapter on each of those things. Here are some things that you will see. Here are some ways that we treat it. all the comorbidities. Even Dr. Yeoman wrote a beautiful chapter on CCI, the neuroanatomical findings that are very complex and hard to understand. But yeah, there's just a chapter on all the different things and different ways that you can treat. It's not a formula because everybody is different. You'd think you're treating one illness, it can't be that hard. It's just one illness. You should be able to figure that out and be really good at it. But it's unique for every person.
I think one of the big things with it is the sections on the comorbidities, because it is one illness, but there are so many things that go alongside it. And does that fall within the same illness, or is that a comorbidity, and the way in which you treat them together separately? It's like one of those puzzles that just gets ever more complex the more layers that come into it. And you're dealing with the MECFS cohort of people that have been sick, like your daughter, for 10 years. And that length of time of having the symptoms and stresses on your body, how that has then chemically, biologically changed the body.
Right.
There are so many strands to it, aren't there?
Yeah. And it's a guide. It's
a way of trying to unravel that a little bit and see each piece.
Trying to, like, for example, at my clinic, we have primary care and we have several nurse practitioners there. And I picked one, bless her heart, who I said, I'm going to give you my patients. That when I hear about someone, I'm going to send them to you. She didn't necessarily say, okay, great, but she's been willing to do it. So I gave her that. And so we started with sort of some patients who were maybe mild with POTS. And so we really focused on how do we treat POTS. So she can pull up that chapter and really read about it and then kind of expand from there. Because when I first started, MCAS was pretty foreign to me. POTS was like, okay, I can handle this. And so I had to kind of stick my toe in the water just a little bit at a time before I felt more comfortable with it. And so again, it's just a place where people can go, look, read. There's resources so they can find more information if they're interested. Hey, I think I'd like to try treating someone. This person sounds like they have MCAS. Oh, look, there's all these treatments that are already approved. They're FDA approved drugs. I'm not doing anything out of the box. I'm doing things that can even be found over the counter. So it gives them a comfort level and helps them. It's hard to do things out of the box without something on paper or something in print where you feel like that's okay to do. So trying to give people that information.
And that's another thing that you do both in the clinical care guide and at the Bateman Horne Center is you layer these various FDA, there is still no FDA approved treatment for MECFS, but you layer various FDA approved treatments to alleviate people's symptoms.
Absolutely.
I know that you're a big advocate for LDN.
Mm-hmm.
You use that quite effectively in a large number of your patients, I believe.
I love LDN. I really do. You have MECFS, right?
I have long COVID.
You have long COVID. Well, do you have MECFS secondary to long COVID?
I don't think that I do now because of that 50% threshold that you need to fulfill, which is an interesting thing. I absolutely understand that you need to have a benchmark, but that's only because during the last 6 months, I have made considerable gains in my health.
That's wonderful.
But until that point, I don't think I would necessarily have properly fulfilled the criteria for MECFS. And yet I was affected every single day of my life by long COVID, and probably half the time for a good 3 or 4 years, I was unable to get out of bed.
Well, do you have PEM?
Yes. Now I think it's much more managed.
That may be why you're doing better, right?
Well, this is an interesting point because I do really, really want to go into detail with you on the PEM.
Okay.
On how to manage, recognize, and deal with the PEM once you're actually in it. Mm-hmm. But one of the big things with once you reach a stage where you're vaguely functional is understanding the way in which that PEM is always changing, or your thresholds are changing. Mm-hmm. Because, and I've spoken to Dr. Bateman about this, I've spoken to Dr. Klimas about this, that point at which you think you're fine, you think you're doing okay, so you throw yourself way too far into life. And so I've been doing pretty well for 6 months, but I can feel right now that because I'm trying to live at a higher level than I have been in the first 3 months of feeling better, I was so gentle with myself. And then you start pushing it and start pushing it and start pushing it. And so whilst a lot of what I'd like to discuss now is for the people who are really in the thick of it, needing to understand pacing just to get through their everyday activities, I would love to also touch on long-term strategy, because I don't know if any of us ever completely lose certainly the sort of hangover or the shadow of what we have been through. But I don't know if we actually recover from these illnesses.
Agree.
So let us talk about you use LDN, you use things to treat MCAS, you use things like the Nasoline test to understand POTS and orthostatic intolerance. But what I would love to hear from you today is your understanding of post-exertional malaise as you've seen it both in your daughter and in your patients. And so let's first of all start with patients just understanding or recognizing what PEM, post-exertional malaise, actually is in them.
So post-exertional malaise essentially is when you exceed, and let me say this at the beginning, when I use terms, I try really hard to make sure that it's not ever a failure on the part of the patient. I don't ever mean that, but sometimes the words I use I don't want that to be misinterpreted. But with ME/CFS or with long COVID, there is an energy threshold that you want to stay under. And sometimes when our exertional levels exceed that threshold, then we experience PEM, post-exertional malaise, which is basically a worsening of all of your symptoms. It can incorporate new symptoms. It's associated with fatigue, but it's not just fatigue. I almost hate to use fatigue in the definition because people get really hung up on that. And they think that's all it is. It's so much more. You exceeded your capacity, and now there's a payback. And it's a payback with worsening of symptoms. There may be additional symptoms. Your orthostatic intolerance may get worse. Generally, it's delayed after the exertion. Sometimes it's immediate, but generally it's delayed. It can be delayed 2 to 3 days. And I'll tell you, I've noticed lately, again, I have walking experiment in my house. My daughter, she'll laugh if I say that, but and noticed the other day, it was 4 or 5 days later. She had done some things and I was worried. I was like, oh, we got away with that. And then 4 or 5 days later, I noticed the fade. And I was like, okay, that's interesting. So sometimes it can come even more than 72 hours later. Generally, the recovery takes at least 24 hours, sometimes can be months for people. But it's essentially impaired recovery in response to an exertion.
Just to pick up on that point, which I think is really important because there is so much emphasis put on exhaustion, put on fatigue. And I know through my experience of this, a lot of people who say, but I don't have PEM, I don't suffer from PEM. However, that's because they are attributing it to that fatigue state, that exhausted state. There are two things in this. A lot of the time they will have exacerbation of other symptoms. Maybe it's the heart palpitations. Maybe it's the difficulty in breathing. For me, it was definitely the headaches, the migraines. But the other thing for patients who are in these states is that they are often in an over-adrenalized state. So that fatigue feeling, that exhaustion is sometimes not necessarily recognized as such by the brain because of it's almost like a buzzing that I used to have. So I thought that I wasn't tired. But it's because your body is in some kind of overdrive.
Mm-hmm.
So I think it's not something that someone has mentioned before on this podcast, but I just wanted to highlight that point that post-exertional malaise does not necessarily mean that you end up feeling exhausted. It can often, but
Certainly.
Yeah.
And sometimes it's more cognitive. And I think too, I noticed this in kids especially, the brain fog, I think really makes it difficult sometimes to recognize things. I've noticed that too with adults. I think with brain fog, you just can't think as clearly and you don't recognize, you aren't as self-aware, I think.
Yeah.
And so I think that it doesn't affect everybody the same, but I think for some people it can be hard to sort all of that out, even just because of the brain fog.
And so the place that we would like to try and get to is possibly a place where people are not pushing themselves into post-exertional malaise. But I guess that we need to find out that threshold. We need to find, how do people recognize when they are going into that post-exertional malaise, and what do they do at that point?
Right. So it really is hard, especially at the beginning. First of all, people are functioning, depending on how old you are. If you're 30 and you get ill, well, for 29 and 30 years, you've functioned in a certain way. Now, all of a sudden, everything has changed. It's like you go outside and gravity is no longer affecting you. The rules have changed. You're in an upside down world, and you have the only disease that this occurs in. So unless someone has the same problem, they don't understand. They can't, it's just really hard to wrap their brains around. Even medical professionals have a hard time wrapping their brains around this, even when confronted with all of the evidence. It's very strange. First of all, I want to recognize that it's just hard to figure out. But there are certain signs that can be helpful. If your heart starts racing, if you have palpitations, if you start to have some brain fog, maybe a little bit of word finding, hard to concentrate. I had a patient tell me one time, oftentimes her PEM was triggered by going to the grocery store. And she said, I finally realized when I'd have a hard time making a choice, I knew that was my signal. And she knew that's when she had to do something different. I have a patient whose teeth hurt when she is becoming too physically active. So there's little signs like that can occur. And that's sort of the early signs of PEM. They may have chest tightness, trouble breathing. But recognizing those signs, if you can do that, there's also other things. There's physical signs too, right? You can also have heart rate monitors, and we can talk more about that. That if you have something, a wearable of some sort, or for people, I always want to make sure I give you examples for people who can't afford things like that, because when you're this sick, you have to spend a lot of money on your health care. Mm-hmm. So if you can't, let's teach you how to check your pulse. And if you're starting to feel like maybe I'm not sure how I'm doing, let me check my pulse and see what it is. And we can talk, like I said, looking at data to figure out when you're having a problem. But those are symptoms that you may experience. When that happens, the sooner you can stop. Obviously, if you're driving through traffic, that may not be something you can do. With a child you're running after in the store, you can't just stop what you're doing. But as soon as you can, you stop, you rest, you get off of your feet, you get supine, even get your feet up if possible. The optimal situation is to go lie down, get your feet up, earplugs in. I'm telling you, stop as much energy-consuming activities as you can. And it doesn't just mean stopping your physical activity, stop your cognitive activity, stop your sensory processing, turn the lights down, don't have the TV on in the background, eye mask, phones, screens, all those things. Stop everything. It's danger, red zone, stop. Wait till your heart rate has recovered, until you're starting to feel more like yourself. Again, I know, and sometimes I say these things and I hear myself talking and go, for the person that's sitting there going, I'm a single parent and I have to work, good luck with that. I get that. But to the best of your ability, if maybe you can't do that, if you are at work, you stop and take a break if that's possible. Even though you may not be able to lay down with earphones and eye mask on, you can at least maybe stop and take a break. But stopping as soon as possible, getting that heart rate down. And when we're talking about cognitive activities that produce PEM, you may not have elevated heart rate, so just take a break.
And is there any kind of guidelines in terms of the length of time that we need to rest in that? Because for some of us, it really is, you can't get out of bed for 2 days. You can't do anything. Mm-hmm. But is there a suggestion that taking 10 minutes is still something? It's still useful.
Mm-hmm.
Yeah. And even if you don't have the capacity to take 2 days off work.
Right. And certainly, and it depends on where you are, right? If you are, I'm just trying to pace my activities, I'm not in PEM, I don't have signs of PEM. One thing that my resources, a lot of the things I suggest come from Amy Mooney, Clayton Powers, occupational therapist, physical therapist, and then what I've read that Todd Davenport has done. And Amy's an occupational therapist. She's super helpful with little tips and tricks. And one thing she talks about is 2-to-1. For every 2 minutes, you should have a minute of rest. Obviously, you don't necessarily go around 1 minute or 2 minutes and I'm going to stop, what have you, but just kind of a 2-to-1 capacity. Again, if your heart rate's up, you can use that. Get it back to your resting heart rate. One thing that's really important for people to know, what is their resting heart rate when they wake up in the morning? So I really advocate for having a pad and pen at your bedside or whatever you use to log your information, but keeping up with what is your resting heart rate in the morning before you get out of bed. That's a great baseline number to know. Different ways to pace. Some people talk about what's your anaerobic threshold. When you hit that anaerobic threshold is when PEM starts. Baseline heart rate, resting heart rate plus 15. Well, that's pretty darn restrictive, right? If you're 60, now you're at 75. I mean, most of my patients would just have to sit or lay down the rest of the day. So we go maybe a little bit higher. If I say that number, most of my patients just ignore what I say because they're like, I can't do that. We're done. So I'll start at 120 and say, try to stay under 120. If you can stay under 120 and you're not having PEM episodes, we can use that number. If you're still having them, then we're going to have to slow that down. So I want to get you back to your resting heart rate before you get up and move around again, if that's possible. Obviously, if you feel pretty bad and you're down to 75 and you can rest another 10 or 20 minutes, go ahead. There's no limit to that. But I find that most people, if they feel good enough to go, I can't get them to stop. I have pediatric patients and their moms will say, I don't want them to get deconditioned. I want them to play. And I'm like, I cannot stop a kid from playing. If all of a sudden they're better, and I do have patients, pediatric patients with long COVID, who some have really improved quite a bit. And so where they started and where they are now is very different. And they just started doing more. And it's hard with kids because they don't express themselves as well. Adults as well, they'll start doing things. And so I don't think you have to worry that you're going to overdo the rest.
Yeah. On a side note, do you think that kids, whilst it might be harder for them to express things, are actually more aligned with how their bodies are feeling? So if they are feeling shattered, they know they're feeling shattered. Whereas adults have much more that sense of duty and they'll just push on through.
Yes, kids are hard too for another reason. They may feel like, okay, I just want to go lay down. That's what I'm going to do. They don't necessarily have that. And it depends on their age, right? They don't have that guilt maybe that adults have, like, why am I still laying in bed? They haven't been old enough to be conditioned that you have to be a certain way or a certain function to be a normal person who's worth something, which obviously I don't subscribe to that belief. But kids are going to just lay down when they feel bad. I feel sick, and they lay down. But the adults come around behind them and say, we got to go. Come on, it's time to go. We got to go to the store. We got to go to this activity or that activity. Your brother's playing baseball. We got to go. And they're at school. The teacher's like, get your head off the table. You got an assignment. And their lives are ruled by other people who don't feel what they're feeling. So they don't know. And sadly, sometimes parents don't get it. They don't believe it. And they'll keep pushing their kid. Or they do believe it. And their kid goes to school, and despite talking to the school, they don't get it. And so off you go. And kids just don't have that autonomy.
Yeah,
The older they are, the better. Teenagers are hard because they want to live. They want to experience all these fun things. And it's really, really hard to slow them down. But the disease will.
Yeah. Do you think that the pushing through in PEM, especially in those early days when you don't really understand it, you don't really know what your body's going through, does that slow down any potential recovery? Does that build up in terms of its detrimental effect?
Yes, I do believe.
Yeah.
I believe that it absolutely contributes. And when you're in post-exertional malaise, it's very hard to treat your symptoms. When you're in post-exertional malaise, my treatments don't work as well. I learned the hard way, don't start new medications when a person is in PEM. That goes very poorly. Every side effect. And I learned this at home. I learned that at home, that if you're in PEM, you give them medication, they will experience all the side effects. They will not experience any improvement. And then you mark that one off the list incorrectly because, it's really because they were in PEM. You need to try again when they're not in PEM. And you need to start low and you need to go really slow and titrate up. Everything's different. Like I said, everything is topsy-turvy.
What is that physiologically, biologically? What is that means that medications don't work? Because if I reflect, the majority of things that were tried on me were probably tried when I was in a massive, pretty much constant state of PEM, because we didn't understand. We still hadn't equated at that time that long COVID was this similar disease to ME/CFS in the way that it was a post-viral consequence and the way in which we needed to consider it. So nothing worked for me, but then I think I was probably in PEM for 2.5 years.
Right. Different things can be contributing. One is you could be an MCAS player because you have PEM. When you're in PEM, all your symptoms are worse. Many of my patients have mast cell activation disorder.
Me too.
And, so when you're in a flare, your body is primed and ready to attack any new thing, and excipients in the medications can cause a problem. Another thing is your dysautonomia, right? Always think about those nasty excipients that can cause all sorts of problems. Again, healthcare is expensive when you have this disease. So many times my preference is to compound things, but eventually you have to pick and choose your healthcare dollars. But excipients can be an issue. The autonomic nervous system is on overdrive. So you get exposed to something new. The body's just like, no, thank you. I would not like to participate in this today.
It's almost like a hypersensitivity across the board.
Yes.
When the nervous system is dysregulated like that.
Right. Hypersensitive to everything. The other thing is, you think about it, your mitochondria aren't functioning properly. There's energy taken when you are taking new medications, and you're just not ready for that. You may not absorb the medications properly because you're in post exertional malaise and your digestive system isn't working as well. So all sorts of reasons, maybe all of those, it may be none of those. I could be completely wrong, but that's where I come down on that.
And is that mitochondrial function more dysfunctional in the PEM phase? Okay, interesting. So if we want to avoid that hypersensitive overdrive state that we've reached for PEM, talk to me about the strategy that you use with your patients to help them understand how to pace, balancing their activities and their energy to enable them to possibly live slightly better, live slightly more.
So every person's different, right? And I really try to learn my patient and learn their personality. And I always tell them, give me feedback. If this sounds like something, I think we all think about ourselves, right? I think about myself. What would I do well with? And there are certain things that I know I wouldn't do well with. I'm a person who I like data. If I see data, I go, I get really obsessed on my ring. What do they give you, like an age? And like I look at that age, like I want to be younger. So what do I need to do? I have to sleep better. Oh no, I'm gonna have to meditate now. Okay, well I'll meditate, even though I'm really bad at that. But now I try to meditate so I can get that number down. I want to see a better number. So if you give me numbers, I'm gonna act right. There are other people though, they're like, I'm waiting for that alarm to go off to tell me my heart rate's high, so they get stressed and anxious, and the heart rate goes too high because they're stressed and anxious about it. So you have to know the person. But the first thing I do is let's kind of figure out your baseline. So many people are in, I call it low-grade PEM. And it's my term that's not scientific. This is just something I say because it resonates with me. And so they'll tell me, yeah, I work and then I come home and I'm so tired. I don't even want to cook dinner. So I lay down and half the time I fall asleep and I get up and go to work again. Do you feel good when you're on your way? Not at all. No, I feel terrible. So I work weekends on Friday. And what do you do on the weekend? I'm mostly on the couch or I'm in the bed all weekend. So all they're doing is working. And they do that because they have to survive. And they're in PEM the whole time, but they're pushing and pushing and pushing. And then it starts to become, now I have to miss a day every so often. And then next thing, they can't go into work at all because their baseline just slowly, gradually gets lower because they're constantly in PEM. But it's not that obvious. Oh, I went on a hike and 24 hours later, I was very ill and I was in bed for 4 weeks. That's obvious. The other is not so obvious to people because they slip into this. They know something's wrong, but all they're doing is keeping their head above water and surviving. So I'm like, let's step back and analyze. And if there's any way, one thing I like to do in some people, again, depending on the situation, if there's any way at all, what can we do to have you maybe not do work for a couple of weeks. Let's see where you are. If you don't do much of anything except kind of stay home, rest, do your basic activities, are you in PEM? Do you feel better? Does that improve your symptoms? If it does, then we can kind of gradually increase your activity. That's in a perfect world where we have support systems for people who are sick and they're not going to get into a financial crisis because they missed work. I had someone I talked to yesterday. She said, I absolutely cannot do it. I cannot. So I said, okay, let's see what we can do. So what can we reduce? What can we ask your family to do for you? Let's get your activity level down. Try to get it down low enough so that you're not constantly in PEM. That kind of gives you a baseline. And then you can expand from there. I'm feeling, especially if you have this routine. I saw something someone had posted on Facebook, and I thought, this is a great idea if a person can do it, is to kind of keep the same routine, the same activities, and then when you go out of that, at what point do you have a problem? So that's one way. Another way is to use that heart rate. Remember, we have our HRV and we have our resting heart rate. And what is your heart rate right now? The HRV kind of gives you trends. It's more of a long-term picture. And your HRV, you want it higher, the higher the number. Everybody has their own number. I'm not saying you have to be at a certain number, but like if you're at 50 normally and you start to notice, it's been 48, 47, 45, 42, you're doing too much. That's your signal to let's get things back on track. If you wake up and your heart rate is normally 60 and it's 90, that's today. Today, we have to get back on track. Today, don't go do the things that you had planned maybe. So those are some ways that you can notice what's going on. So that's kind of how to recognize it. But then what are we going to do to try to not have PEM, right? What can we do? What are the little things that we can do? And if you have an occupational therapist or a physical therapist who is educated in post-exertional malaise, that's very helpful. It can be the opposite of helpful if they aren't familiar. So be careful with that. But if you have they're gold. They are golden. The ones we work with at the Bateman Horne Center, I just gather nuggets of wonderful information from them all the time.
And that's because they're able to offer just simple practical advice to patients on
Absolutely.
how to tailor their particular lifestyle. So maybe
Yeah.
drive at this point instead of walking, or
shower chair. That's one of those things that people don't, I'm always like, you use a shower chair, right? What? No. Get a shower chair. You can stand in the shower. And sometimes people go, but I don't want to do that. It makes me feel like an invalid. And that's a terrible word, but that's what people will say to me. I'm like, but you're not. You're trying to conserve your energy so you can eat dinner with your family tonight. Think of it that way. Think of what you want to do. What can you give up, or what can you get rid of? One patient I had, I was telling her about pacing, and I said, there's things you don't like to do that are just obligatory, that aren't necessary. Don't do them. She said, so I don't have to listen to, she had a coworker that used to call her and just talk for an hour about stuff she didn't like. I said, no, stop. Don't listen to that. And it was funny because she was like, oh, this is great. This is relieving. I'm just going to stop all these things that are unnecessary. So prioritize, think what you really want to do and save your energy for that.
I think that is one thing that I've always said chronic illness gives you is,
yes,
because you are only able to give your energy to certain things, really, really focus and make the things that you give your energy to the things of highest value to you. And it really enables you to reframe your life in terms of who gives me energy, who am I going to spend time with that helps with my energy, not drains it? What are the activities that enhance my energy rather than drain it? I know that's a perfect world situation and we all have to do jobs and we all have to do chores, but that balance of finding the things that don't drain you.
Right. And that's something I talk about with kids. So this may not be such a popular thing to say, but I think school is very important. I think learning is very important. But if you have a child who is becoming more ill because they are in school, then we need to modify what they're doing. Don't just say, okay, you can go home and not come in, and I'm going to give you all of the same assignments. That's actually harder. That's what happened with my child. Here's all your assignments. Now there's no teacher to help you with them.
Yeah, and no friends, none of the kind of joy that you would get.
Right. Let them have the social activity. Again, it depends on the severity. If it's a person who's mild, that's different. But if you have a person who's moderate, severe, very severe, I want them to have the 10 minutes with friends rather than 10 minutes of math. We'll get to math later when they're improved. And that's my hope. They're going to be improved. But figure out those things that are important to you. Think about the extraneous things you're doing. Like, I'm going through the grocery store. Yeah, I like to pick out things, but is it really that important to have to handle the fruit? If you can save the energy and get it in a quick list where you pick it up or they bring it to you, even better. Conserve your energy. My daughter lives upstairs. And I said, okay, when you come down, bring your plate down. If you come down, bring it with you. Don't go back up and do that. Bring it at the same time. Do things that are efficient. Work smarter, not harder. I used to work harder, not smarter, not intentionally, but that seemed to be my policy. So now I'm trying to work smarter, not harder. Anyway. You get it. But try to be efficient. Sit when you can. If you're doing laundry, don't stand and do it. Sit and do it. When you're studying, recline. Get in the recliner with your feet up because you get blood flow to your brain. You can think better and it isn't so fatiguing. Turn off the extraneous noise. Don't have the dog barking in the background. Have a lamp instead of a bright light overhead when you're doing your homework. Those kinds of things. Remember, everything we do consumes energy. Eating, digesting food consumes energy. But the lights, you're consuming energy when your brain is processing those lights, the noises, the sounds, emotional things, whether good or bad. And that's a particularly cruel thing, right? I'm excited because my friend had good news and now I'm in PEM. What is this disease? It's just incredibly cruel.
And in addition to that, emotional, the cognitive, because I think cognitive pacing is a massive area where adults particularly fall down because they feel, well, I've not physically done anything. I haven't exercised, but I have sat on my computer and worked for 8 hours. And then they wonder why they're still getting the physical exacerbation.
Right. It's hard to put those together. Most of the time, cognition doesn't bother you. So this is a new concept. What happened? It's funny because sometimes when people tell me what they're doing, and again, this is not a criticism. It's just interesting to me how I can go, oh, there's a pattern there. And they're like, I never thought of it like that. Again, because they're not used to thinking about life in this way. It's just so different. So it's hard. I'm telling you, if it were me, I'm slow to the table to figure things like that out. I just keep trying to bulldoze my way through. That does not work. But it's hard. And again, you throw in brain fog. It's hard to figure some of this out.
Yeah, it really is. So how can people recognize if it's actually a cognitive or emotional thing that has pushed them into PEM when they're there frustrated thinking, but I've rested so much physically. I've sat down to cut the vegetables and I've driven instead of walked and I haven't done any exercise. I've not done anything physical. How can people then start to recognize that possibly it's that cognitive?
So one thing is keeping a log. I know that that's hard to do. I know that it's hard to keep a log, but if you can even just simple, you don't have to write out the whole thing, but maybe good day, bad day, went to the store, stayed on the computer 3 hours, and just so you can kind of start to pick out patterns. Look at that. So let's say you kind of have done that. On Friday, you experienced PEM. Now you can go back and look, what did I do Monday, Tuesday, Wednesday, Thursday, and start to see a pattern. Cognitive clues can be things like when you're doing something cognitively. And I have one patient who says, I know when I'm reading, because part of her job is reading. And she says, I know when I have to go back and read sentences over and over again, I know I have to go take a break. Or I can't concentrate, I'm losing my train of thought, or maybe other types of cognitive activity, I'm having more trouble finding my words, I feel fuzzy. Those kind of symptoms are the clue to slow down. Sometimes just check in with yourself. And how often you check in with yourself depends on how ill you are. If you have mild ME/CFS, and you normally can do your work on your computer 30 minutes, check in at 20 minutes. How am I feeling? Am I still as good now as I was 20 minutes ago? If you're feeling like you're fading, okay, just taking the time to think about it, just doing that. And I'm really big on setting timers for things like that, like during activities, whether they're cognitive or physical, with my daughter, because I have found that hope is always there, right? And sometimes we would do something and I was so hopeful because she's having a good time. Everything's great. I see she's experiencing something. And I'm like, okay, let's just keep going. And then on the drive home was that sick feeling that she would become quiet and I would know, oh no, I've let this happen.
Too far.
I am not to be trusted. You cannot trust me for that. I have to set a timer. We decide before we go, okay, it's going to be 20 minutes that we are at the dog shelter, because that's usually where we were going to see the dogs at the dog shelter. And we would go pet them and play with them, right? And so now I'd be like, at 20 minutes, I let her know we have 10 more minutes. And she learned at 10 minutes, we were leaving. That's what we had to do. I had already thought and decided. I can't make the decision in the moment. Can't do it.
Do you think that employing that kind of strategy where you are actually reducing what you think in that moment you possibly could manage, you're putting that time limit on it, does that strategy help you incrementally increase that over time?
I think the less you're in PEM, the better everything is, because you're not having those symptom flares. Your medicine is working better. You're less stressed. You're less upset. You're less anxious, because I can't imagine what it must feel like for your body to betray you. That must be very scary. And not having as many of those feelings has to help, right? And so with time, just like repeatedly crashing, you start to cycle downward. I see that people, when they aren't crashing, start to cycle upward and everything starts to come together, right? I had a patient who we had done a lot of things. She was in a pretty decent place. She still had the occasional flare, the occasional PEM. And she started really, I hate to use the word aggressive, because doing anything aggressively when you have ME/CFS is hard, or long COVID. And I say that term, anyone who has PEM, okay? So every day she would take a break mid-morning. She was kind of moderate. She was moderate, more housebound, but she could do little things around the house. She didn't do the shopping. So that's kind of her baseline. So she started taking a 15, 20-minute break in the morning, midday, and afternoon. And on Wednesdays, the whole day was break. And she said after about a month or two, she said, I am feeling better. My energy is a little bit better, but if nothing else, she said, I am enjoying everything more because I feel better when I'm doing it, and my quality of life is improved. And the other thing was, she was empowered. She was like, I have more control over the disease rather than the disease controlling me. And that meant a lot to her. And so I really want to help my patients, and I want to help people listening. I want to help you gain some control of your life again. Because again, that's one of those things that really hurts my heart to know. I can't imagine how that feels. I can to a degree, because I know how I have no control sometimes with my daughter. I can't, I should be able to fix this. But I can't. So here's what we can do.
Yeah, the strategies. It is a horrible feeling when you can't trust your body. So I think that is hugely powerful tool. If you can give people some sense of agency over their own bodies and lives. And what you're suggesting here is not actually going and seeking the most expensive medical care. This is strategy that people can employ themselves at home.
Right.
Obviously, it's helpful if you have someone like Amy Meany to refer to, and there is guidance in your clinical care guide over this. But just those ideas that you've put there that people can take, and it might not be the grocery store, or it might not be 15-minute breaks in the workday, but trying to take the essence of what you're saying in terms of those pacing strategies and apply it to their own lives. I know with cognitive impairment, it might be challenging. Maybe sit down with a family member or loved one to try and build something together.
Yeah.
There are tools there. In terms of for those people that might be able to afford it, and I know that we don't want to dismiss the people that can't. You mentioned earlier wearables and using that kind of thing. Now, this podcast is brought to you by Visible, and we're never here to promote a product. I am here to distill the science and the information to everyone. But in terms of wearables, you actually have had experience with your daughter and patients. Can you talk to us about how that wearable data or these sort of devices enable patients to focus on some of those pacing elements that you've talked about? And some of it is not just the actual data that's coming in, it's the data that they're inputting, because it helps create a framework for that journaling or that record keeping.
Right. So most of my patients have some sort of a wearable, and I really like it because a lot of times they can download the information and send it to me in the portal, and I can look at patterns. We can look at their sleep, their HRV. The HRV is kind of a more long-term number that I look at and they can look at, but we can start to look at patterns that way. Visible is new for us. We just got it. My daughter has never wanted to do a wearable. And I said, I have patients that have this. They really like it. I love the pace points thing. I love that. I think that's so cool. Again, numbers. I'm a numbers person. So that would be really helpful for me. And she said, sure. Okay. So she got it. And before, she's been very resistant. She got it and she brought it down to me the other day and said, so can you tell me what this means? And what's your HRV? She wanted to know what mine was. And we were comparing who wins. And so we were looking at all that. And then she said, but you are old, so yours would be different and all these kinds of things. She didn't say it like that, but that's how I took it. So anyway, but that was really exciting to me that information was helping her make good decisions. And it wasn't me having to help her make good decisions. She's a young adult now. And it's hard because when you start out at 10 sick, it's hard. And so I'm at the point in my life where I'm trying to teach her how to navigate and manage on her own, because that's my job, right? To teach her how to be independent on her. What if I'm not here? So this is helping her. Instead of me being that voice that's like, slow down, and that becomes annoying after a while. So now she is able to be a bit more autonomous with it. I tell you another thing that was really helpful. So I've tried to get her to do breathing exercises for years. And there's a place on the Invisible app where you can do a breathing exercise. And so we did that, and she had positive feedback with her heart rate. And so okay. And I said, so let's look at your sleep and let's do this for a couple of weeks and let's see if your sleep changes. And we did, and her sleep improved, and she could see kind of the correlation. And so that has reinforced the importance of the breathing for her. That was huge for me. I've tried to get her to do this for a long time. So that was pretty amazing. I will try anything out there. I'm always trying things, and I have had a lot of things that are disappointing, but that was really cool. That was really neat. I don't want it to sound like I am running a commercial. I really don't, but the price point is not horrible at all. So
compared to the others that your patients are using.
Right. And I didn't know what the price was until I bought one. And so I was like, oh, okay, well, this isn't too terrible. And I feel sometimes I'm everyone's mother. I feel like, all right, I try to be everyone's mother, and it's not my job, but I have that mothering instinct. And so I'm like, okay, we got to save your money. We can't spend all this money. I just wrote 3 compounded things. So now I can't tell you to go get a wearable because I've just asked you to spend $1,000. Because truly, it's hard for people. It's easy for me to say, go do all these things, but you have to practically do it. And so I try to think about those things, but it really wasn't bad. So I can't remember what it was, but I remember being pleasantly surprised.
The thing with that is whether people choose Visible or another wearable is that rather than relying on your mother or on your physician or on completely intangible measures, what you're getting there is data. Mm-hmm. And whilst not everyone's brain is necessarily geared up to understanding the intricacies of data, there's something about it that corroborates what you're going through. Mm-hmm. It almost gives you a readout that's reflective of what's going on in the inside of your body. Mm-hmm. And I think that validation can be hugely important for people. Mm-hmm. Mm-hmm. That's not to say that the physicians like you are not validating patients, but just to have that on a day-to-day basis, not only once every 6 months when you see a physician, is huge.
Well, I mean, people who have this disorder, I see them gaslighting themselves. And it's because they're being gaslit every day by peers and family and unfortunately healthcare. And so they start to doubt what they think. They start to not trust their instincts. And this helps them get that back.
Yeah.
And so it helps with that. And again, that feedback. And also, here's another thing. If you can start to recognize, like you see that HRV dropping, now that's a cue to you. What am I feeling? You may be surprised and go, oh, it's causing this or that symptom. This isn't what I thought going into PEM would feel like. Now I have another clue. Again, I was on a hike with someone who has post exertional malaise, and they said, I need to go back to the car. And are you okay? Is your heart rate? No, my teeth hurt. Your teeth hurt? Okay. Then we did this whole conversation. And then I started asking my patients, do your teeth ever hurt when you're in post-exertional malaise? It was not, it was more yes than you. Yeah, it was not uncommon to hear, at least in the 5 or 6 that I asked. About half said, oh yeah, I do that. Or my tongue hurts or something mouth related. It was really interesting. So just you can use that and go, okay, here's my numbers. I'm going to start slowing down now, but what am I feeling right now with this low number or this number that's not optimal?
And I think that's an interesting point to make, because sometimes that HRV reduction is considerably prior to the real symptom exacerbation. So if you can notice that the HRV is dropping before you get into the real depths of the crash.
Right.
Do you find that patients are then possibly able to bring themselves back before they fully enter PM?
I think it's possible. It depends again sometimes on how severe they are. If they're if they're severe, it's a little bit harder. If they're more mild, and it depends again on how much they rest. If they go all in, they're able to take the day off and just really spend it home, kind of sitting on the couch, lying on the couch. There's so many variables, it's hard to say, but yes, in some instances for sure. And if nothing else can lessen it.
Are there any other things that you'd like to share with people when it comes to really trying to get a handle on this idea of pacing and avoiding PEM?
Yes, healthy eating is very important. And people, what kind of diet? Well, to start, a healthy diet, just a healthy diet, heavy with fruits and vegetables, organic, wash them. All the chemicals that our foods are sprayed with, you want to, and I won't go into it because I can't really remember now, but if you do a Google search of which foods are most likely to have pesticides, there's like a list of 10, and you can figure out, okay, so maybe I want to avoid those and go more with these, but try to be healthy. When you're experiencing PEM or going into PEM, even digestion takes up energy, right? So do things that maybe are a little more easily digestible, that you don't have to chew so vigorously. If you're severe, chewing can be difficult. Swallowing can be difficult. So you want things that are easier to swallow, things that are easier to eat, soft foods, things like that. Don't eat spicy foods in PEM. It's just more things for your body to experience the sensations, etc. So healthy habits, controlling your triggers for, like, if you have MCAS can trigger PEM. So you want to try to avoid your triggers, try to identify your triggers. And again, sometimes I say things and think, oh boy, that's a hard thing. But I'm going to ask you to try to do it, is to try to reduce your stress level. Stress, when you have stress, your body releases cortisol. Mast cells have a receptor for cortisol releasing hormone. So when you're in stress, you activate your mast cells, which can activate and worsen your POTS. So you can see the spiral that can occur that can lead to PEM. So trying to do things like that are healthy. Focus on you. Do the things that are healthy for you. Do the things that keep your peace. And that can be very helpful.
Okay. In an ideal world, there are all many things that some people will say, these are really not options for me. But I just want to reiterate, you're saying do as much of them as you can to try and get your body back to some sort of homeostasis.
Right.
And hopefully the more of these strategies that you can implement in the immediate term, it can enhance things in the long term. So we're talking about, instead of living for the rest of your life with this severe situation, perhaps implementing some of these strategies now might enable sooner for your life to be improved.
And again, sooner to have some control, for you to control, not it to control you. And let me say, though, too, sometimes this disease is cruel and you can do all the right things. So I don't want anyone to feel like they feel like they're doing all the right things, that's a failure on their part. Sometimes this disease is just cruel. But if there's any way to enlist other people to help you to figure out those things, like with OT, that can be helpful.
Dr. Melanie, this has been such a pleasure. I feel like we've only scratched the surface of your knowledge and your clinical experience and your experience as a mother. But I hope that what we have given to people is a little bit of a guide of how you can start. And I guess the biggest thing for us to say is do check out the resources at the Bateman Horne Centre, because it is a remarkable organisation. And the primary function is to help people to drive this forward. So
absolutely.
Thank you so much, Dr. Melanie.
Thank you so much.
So you, my listener, if this conversation was helpful to you, and I think it's so packed with ideas and tips and genuine lived experience, if it rang true, if there are nuggets in there, please can you go and share it with someone for whom it might actually make a difference to their day, for whom it might make a difference to their illness and their life. It would be really, really appreciated. Because actually what people like Dr. Melanie are trying to do is help as many people as possible. And by creating these podcasts, by creating these episodes, we're trying to spread that information more widely than a single individual or centre can do. The Bateman Horne Centre is an absolutely phenomenal resource. Check out the show notes for links. But if we can play a part in sharing their knowledge and spreading the understanding of these conditions with this podcast, we are helping not only them as an education centre, but we're impacting the lives of people with complex illness. This conversation was actually prompted by a listener who responded to our Rob Wust episode 17, which delved into the scientific understanding of post exertional malaise, asking what we are supposed to do about it. I say this is the first in what will be multiple conversations from different practitioners to really try and give you the tools to pace and make steps towards understanding what you can do on a daily basis to try and alleviate your symptoms and regain some control over your illness. So please share this episode, review it, leave a rating, give me feedback, engage with us so that the information here has the greatest impact, the greatest reach. And we will continue to bring you the brightest voices in this field. Thank you for listening to Make Visible. Please do like, follow, or subscribe to listen to our next episode where we'll be uncovering more insights into complex chronic illness. This was brought to you by the team at Visible, a group of scientists and engineers whose lives have been affected by energy-limiting health conditions. We're building wearable technology that's helping 100,000 people measure and manage their complex chronic illness. To find out more about what we're working on and how Visible could help you, visit our website at makevisible.com.